Immunization is one of the basic practices in modern medicine, and one would expect it to be without controversy. However, it is not so. The, the immunization schedule given by CDC, the WHO, as well as by the Indian government and the Indian Academy of Pediatrics do differ, making the final choice on the shoulders of the general practitioner or the pediatrician who is immunizing the child. One will not be able to make an intelligent choice between these schedules from well-known organizations unless one knows the scientific basis behind these schedules. I would dwell on two immunizations today, which are usually given in newborn period: hepatitis B and oral polio vaccine. BCG I might deal with in at another time. And I am Dr. A. Padmanabhan, a senior pediatrician. I will first take up hepatitis B vaccination, and the first few slides I would stress on the importance of hepatitis B vaccination. Hepatitis B is the cause of nearly half of the cirrhosis diagnosis, 80% of hepatocellular carcinoma, and 1 million deaths yearly worldwide are because of hepatitis B. This causes hepatitis B virus infection, second only to tobacco as a major carcinogen. The risk of infection in childhood born to hepatitis B positive mother ranges from 10 to 85%, depending on the mother's hepatitis E antigen status. It can be as high as 85%. You miss the injection, you delay, that is the risk the child runs. Now, the younger the acquisition of hepatitis B infection, higher the chances of becoming a chronic carrier. It is believed that as many as 90% of those who are infected at birth go on to become chronic carriers, and 25% of chronic carriers will die of chronic liver disease. Therefore, to prevent transplacental transmission, mother to the child, or immediate postnatal transmission is of vital importance. If you want to know the impact of this vaccination, straight from WHO, 60.1% decrease in hepatocellular carcinoma, 76% decrease in mortality from fulminant hepatic failure, 92% decrease in mortality from chronic liver disease over decades since vaccine introduction in Taiwan. What a great role each doctor who decides on newborn vaccination has, and what importance it is not to make a mistake in that cannot be highlighted in a better manner. The recommended child adolescent immunization schedule up to 18 years by the CDC. We just look at the hepatitis B vaccine. Here is giving a 3-dose schedule is normally given it at birth, end of 1 month, or the end of 2 months, and then it gives at 6 months. Note here that it gives it starts the last dose or the third dose, which they are talking about. The range is from 6 to 18 months. This is an important point to note. And in this, they have again given the reason. As per American CDC, the minimum age for the final dose, whether a third or the fourth. Sometimes, as we have already seen, we sometimes give, the WHO advises you can give a 3-dose schedule or a 4-dose schedule to accommodate the combined vaccines, is 24 weeks. The minimum age is 24 weeks. That is 6 months. Why the WHO does not insist on it? Why is this difference? Now we will have to spend some time in basic immunology to know why the CDC insists on giving the booster dose minimum at age is at 6 months. Whenever you have the B cell responses like this, whenever the antigen enters the spleen or the lymph node, and it is usually taken up by the B cells, converted into plasma cells, produces IgG, IgA of low affinity, low numbers. This is called the extrafollicular production of antibodies, which takes a few days. More important is that some of these B cells are driven inside the germinal center of the spleen or the lymph node, which are formed at that time. For this, the requirement of the T helper cell is required. And once it enters the germinal helper center, the follicular dendricular cells as well as the T follicular cells make them produce high affinity IgG antibodies, increase in number, high affinity number, higher class antibodies, which are produced in large numbers. This is more this is more protective. And some of these antibodies go inside the bone marrow and stay there in between the bone marrow cells. Now, simultaneously as this is happening, the same process from the germinal center, memory B cells are also produced. In the primary response also, the memory B cells are produced. These memory B cells, see this inside the germinal center, you have high affinity IgG and memory B cells. These memory B cells migrate into the follicular phase, remain as memory B cells inside the outer layer of the lymph node or the spleen. And when there is a booster dose of the antigen or the virus attacks, the memory B cells are able to produce large amount of specific antibody in a very quick time, but that is about 5 to 7 days. Within a week, you will find it doesn't have to enter the germ center again. Therefore, the secondary response, the IgG antibodies are more specific to the antigen or the virus and are produced in large numbers. And this is what we want. We want a very good secondary response. Now, the affinity maturation process that's initiated by the GCs, by the germinal centers, extends for several months after the end of the GC reaction. After it starts producing, this keeps on doing it for several months. Consequently, vaccine antibodies with higher than baseline avidity for antigen are induced only when sufficient time has elapsed after priming. Therefore, you have to give a sufficient time after the primary dose. A classical primary boost immunization schedule is thus to allow 4 to 6 months to elapse between primary and booster doses. Hence, the generic dose 0, 1, 6 months is ideal for giving immunization. Therefore, if you give only enough period for the germinal centers to produce maximum number of antibodies, which takes about 4 to 6 months, and then give the booster, it will have the memory cells will have another peak coming up, which we will see later. That is why the CDC is insisting that a 6-month dose is required. Minimum time at which the hepatitis B booster dose is given is 6 months, which is not followed by the WHO. Therefore, it's not immunologically very correct. And remember, very important thing to remember is that in hepatitis B immunization, we require newborn immunity to prevent transmission from the mother to the child, which is very important. But also we require the immunization to last for a long time, because adults are prone for activities, sexual as well as other activities which are prone for injuries, etc. Therefore, we want the immunization to last for a long time. And for that, especially when we are not giving any booster doses for hepatitis B, the 6-month dose becomes very, very crucial. Now we will see what the primary immune response and the secondary immune response are. Immediately after the antigenic exposure, you have the antibody titer here and the day's time interval here. Immediately afterwards, the extrafollicular phase, the antibody starts rising. Once the germinal center also kicks in, it rises rapidly. On the 30th day, that is usually 4 weeks, it has reached its peak. And afterwards, it starts going down very fast. Within maybe 1 or 2 weeks, it goes down very fast. This is called the primary response. When you give when the body comes in contact for the first time with the antigen or the virus. Now, when you give 2 primary doses, the minimum interval should be 4 weeks. This is because if you give on the 2nd week or 3rd week, the antibodies will be present in very high amount and is likely to neutralize the antigen. Therefore, if you want to get 2 primary doses, you try to give it in the interval of minimum 4 weeks. Now we come to the secondary response. The secondary response comes in when the memory B cells have started acting. And when the memory B cells start acting, now we have already seen for the germinal center to completely multiply, produce adequate antibodies, and the maturation of the antibodies to go down and the germinal memory B cells to accumulate, it takes at least 4 to 6 months. Therefore, after that period, when the memory B cells kick in, they rise very rapidly. Here it took 30 days to rise. Here it took 7 days. The peak is reached. Actually, the peak is not like this. It is about 10 to 100 times more than the peak here. Therefore, the peak is very much higher than what is represented in this table. It lasts longer and it goes down. But when it comes down just like here, it rapidly declines. But what happens is when the secondary immune response is generated, the cells which are there in the niche of the bone marrow, they start producing the antibodies, and the antibody level therefore lasts longer. So we want to produce longer lasting antibodies and higher peaks. We want secondary immune response. And for secondary immune response to be kicked off, there should be an interval of at least 6 months between the primary dose and the booster dose. In some places, you would say 8 weeks. Sometimes they compromise. Generally, the best is 6 months. 4 to 6 months is the best time. That is why the CDC gives 0, 1. The second one also acts as a primary dose, and the booster dose is at 6 months. When you give the dose at 0, 6, and 10 and 14, like you are advised by the WHO, you are not giving a booster dose at the right time. WHO looks at the whole world situation rather than purely from a scientific angle. The WHO recommends multiple options for adding hepatitis B vaccine to existing infant immunization schedule without requiring additional visits for immunization. Now, one of the benchmarks for WHO is not to call back again and again for immunization because then the compliance goes down. Schedule should optimize percentage of children completing the hepatitis B series, which can be achieved with earlier administration of the vaccine. And the WHO recommended minimum interval between dose 1 and 2 is 4 weeks. Minimum interval between 2 and 3 is also 4 weeks. Actually, the CDC says between 1 and 2, maybe 4 to 6 weeks. Second and third should be minimum 8 weeks. And the first and the last dose should minimum be 16 weeks, and the last dose should not be given before 6 months. But here the WHO agrees for a shorter period of 4-week interval between the doses. Scheduled with these minimum intervals, 6, 10, 14 weeks, have seroconversion rates similar to schedules with longer intervals. The same number of patients are converted, but lower final anti-HBs concentration. When you have lower final anti-HBs concentration. Now it goes on to say it admits the WHO minimal interval of infants hepatitis B vaccination are shorter than those recommended in the United States. Although data are limited regarding long-term protection for schedules with shorter interval, the alternate schedules are often not feasible. Why the WHO says that you give it by the same time as the other visit? Because this is the one according to them is feasible. You make an extra visit at 6 months, many patients will not come to take it. In addition, concerns about long-term protection are less practical, significant in countries have high endemicity, where most of HBV infections are required in childhood. For more evidence, population-based studies, which are considered the best evidence in areas with a high endemicity of HBV infection, have demonstrated that post-exposure vaccination is highly effective in preventing infection when the first dose is administered soon after birth, second at the age of 1 to 2 months, and the third at the age of 6 to 8 months. What I feel is that even what the WHO says is not fully correct, because when so much solid evidence is there to give the last dose of 6 to 8 months, to compromise on it is a little too much. But I do feel definitely in private immunization, where the patient is likely to come back to you you must be able to give the last dose at 6 months, and especially you're not giving the booster doses. And even I feel one size does not fit all. Even in communities like in many parts of India, like in Kerala, where the population is very much educated, if you tell them, majority of them would like to come back for a booster dose at 6 months. Therefore, to skip the 6 month dose is not scientifically correct, and I don't think it is practically difficult to give it in the circumstances in which we work. The IAP Immunization Schedule 2020-21, generally the ACVIP Committee of the Indian Academy of Pediatrics, which puts up the immunization schedule, customizes it for private practice doctors, and they say they write what is best for the Indian children in the Indian conditions. If you look at we are just looking at what doses they're giving at a newborn period, is a BCG, hepatitis B, and polio. If you look at hepatitis B, they are advising a dose on newborn 6 weeks, 10 weeks, and 14 weeks. 6 months, there is nothing. Therefore, this is just because they want to give it along with the other vaccines, combined vaccine, costly vaccines like Infantrix and Exacin. I think this is not scientifically correct also. It is not right as per the policy of the IAP, which says it's the best for the patients, which we don't look at the ground. In the community, you might have certain conditions, but in private practice, we try to give the best. But this is definitely not the best. But some of the doctors point out that the Nelson's Textbook of Pediatrics 2021 also says if DTaP IPV combination vaccine is used, a 4-dose schedule is permissible, which includes standalone hepatitis B vaccine at birth and combination vaccine for the next 3 doses. This is advised by Nelson, and this is what we follow here. Some of my own colleagues, very learned pediatrician, point out this. This is given in Nelson. Why are you objecting? Not only the WHO, but you should realize one thing, that the CDC schedule for primary immunization in the Western countries is 0, 2, 4, and 6 months. Therefore, the last dose as were given in America or the Western countries comes at 6 months. They don't compromise on that. Therefore, you should not be misguided by this statement written in Nelson's pediatric textbook. Many people raise the issue that with the present vaccines available, a combination vaccine available, it's difficult to give a 0, 6, 6 weeks and 6 months dose in India. Actually, you can do it. If I use the trade name for you, birth you can give BCG, OPV, and hepatitis B. That's monovalent hepatitis B. At 6 weeks, if you give Pentavac, which contains DPT plus Hib and hepatitis B, and IPV, and then you give a PCV, pneumococcal vaccine, one of the 3 trade names, and rotavirus. Rotacil is what I prefer to give. Therefore, this cuts down the cost also, and you are able to give hepatitis B here. Now, if the patient doesn't want 3, the problem here is you have 3 injections. Some patients may not like it and may insist on a less painful injection. But the more costly and less effective option is Infantrix or Exacin, because this is less painful. But SLR vaccines, SLR whooping off vaccines are less effective than wholesaler vaccine. This you have to impress upon them. If they are for it and they are ready to pay for that, it's better to give Infantrix, and it contains hepatitis B also. And 10 and 14 weeks, you don't require hepatitis B. Therefore, you can give Cordravex or EC4, both of which are available, IPV, and pneumococcal vaccine and Rotacil. The crucial thing in this is that the injectable IPV should be available so that we are able to give this regime. If it is not available, then it becomes a problem. Some of them may have to be replaced by OPV then. Now, if you want to give SLR vaccine there, the patient insists, you can give Pentaxim, which does not contain Hib vaccine, and then you can give pneumococcal vaccine and Rotacil. Therefore, at 6 months, you give monovalent hepatitis B vaccine also. Therefore, you end up giving hepatitis B 3 doses, 1 at birth, the second at 6 weeks, and third at 6 months, and this is the ideal for immediate and long-term immunity. Let me tell you one thing here, that the birth dose to be given preferably within 24 hours. If you cannot give it, at least within 7 days. If you want to prevent mother to child transmission, give as early as 12 hours. That's one of the biggest contribution you can make for hepatology if you do that as a pediatrician. Never compromise on that. And number two, never compromise on 6-month dose, because long-term immunity is also very, very important. This looks like a very busy slide, but I think 99% you know everything about it. This hepatitis B immunoprophylaxis for preterm and low birth weight infants. The infants are divided below 2 kg and above 2 kg and below 2 kg. Now infants above 2 kg are treated exactly like full-term babies. It's the same. If the mother is hepatitis B positive, then you give immunoglobulin and vaccine within 12-hour birth. Then immunize in an accelerated immunization 0, 1, and 6 months of chronological age. That's what you do to a full-term baby also. The only difference is, because the mother is positive, you will check for the anti-HBs and HBsAg antigen at 9 to 15 months of age. And if both are negative, that means the child is susceptible. If the HBsAg positive, anti-HBsAg negative, then the patient has already got infected. Now, if he is susceptible, you give a repeat dose, 3 doses at 2-month interval, and retest. Actually, this re-immunizing is effective in more than 90% of the cases, and this is something which we pediatricians often fail to do. Now, the hepatitis B status of the mother is unknown. You give hepatitis B and do the test and wait to give immunoglobulin for 7 days. You have a period of 7 days in children above 2 kg. And then if it comes positive, the immunoglobulin, if the mother tests positive, then you give immunoglobulin to a child within 7 days. If the result doesn't come within 7 days, you will have to give the immunoglobulin. The hepatitis B negative, you know what it is. It's only hepatitis B vaccine, and we have already discussed it. Now, below 2 kg preterm babies, the difference is that it is an emergency to give, because they get more chances of mother to child transmission. At the same time, the hepatitis B vaccine may not be that effective. Therefore, the vaccine you give immediately, but it may not be counted. Now, if the mother is hepatitis B positive, you give hepatitis B vaccine and immunoglobulin within 12 hours, same as the above 2 kg. The only difference is, here you give 3 doses of hepatitis B. Here you give 4 doses, because you don't count the first dose. Therefore, you give at 0, 1 month, when the baby is 1 month chronological age, 2 months, 3 months, and then 2 to 3 months, and then the third dose at 6 to 7 months of chronological age, and again do the test as before and re-immunize if it is required. And here also, if the mother's status is unknown, here you have a leeway of 7 days. Here you have only 12 hours. Therefore, if you don't get the result, mother's status within 12 hours, you will have to immunize the child with immunoglobulin also, other than the hepatitis B vaccine. Now, if you have a preterm baby in which the mother is negative, you can wait to give the hepatitis vaccine till the child is 1 month old. At 1 to 30 days of chronological age, medically stable, or at hospital discharge, you can wait till that time, because if you give earlier, it may not be, and continue with the normal vaccination. Therefore, the main difference is, about 2 kg, you are vaccinating exactly like a full-term baby. Below 2 kg, it is an emergency, but the vaccine you gave may not be effective, and therefore it is not counted. There can be situations in which the hepatitis immunoglobulin may not be available or is unaffordable to the patient. Now, in these cases, hepatitis B vaccine may be given at 0, 1, 2 months. It's an accelerated giving. You are giving 3 doses within 2 months, with an additional dose at 9 to 12 months. This is given in the IAP guidebook alone. And if you follow this regime, the efficacy of prophylaxis with both hepatitis immunoglobulin and hepatitis B is 85 to 90%, and that of hepatitis vaccine alone is 70 to 75%. Therefore, even if you have only hepatitis B, you can protect 70 to 75% of the mothers from transferring the hepatitis antigen to their children. All infants born to hepatitis positive mothers should be tested for hepatitis AG and SBSAG antibodies at 9 to 15 months and revaccinated if necessary. Therefore, in many countries in which they don't have they don't have the money to check the mothers for antibody titers routinely and also for immunoglobulin, the thing to do is to give hepatitis B vaccine within 24 hours of birth, preferably 12 hours. And this is actually, in fact, one of the performance indicators of vaccination by WHO. If you follow this, there are publications which say even up to 90% you can prevent the transmission from mother to child. In spite of all these prophylaxis, it is found that if the HBsAg is positive and HBsE antigen is also positive in mothers, there's a 10% risk of chronic HBV infection compared to 1% in HBe negative mothers in spite of the prophylaxis. And there is some worry in the Western countries that mother to child transmission is increasing even there. And therefore, the guidelines suggest that mothers with an HBV DNA viral load more than 200,000 units per ml, international unit, should receive an antiviral such as lamivudine, telbivudine, and or tenofovir during the third trimester, especially if they had a previous child who developed chronic HBV after receiving HBIG and hepatitis B vaccine. In an era in which we are judged by our failures and not by our success, especially our profession, it might be the gynecologists may take note of this, that nowadays if a mother is positive, probably you will have to, especially with E antigen also positive, possibly you have to do a viral load, viral count, and then give an antiviral treatment after consulting an infectious disease specialist. Now, this practice is proven safe with normal growth and development in infants of treated mothers. If you think that I am quoting somewhere from the latest journals which are of no practical significance, I am quoting from the Nelson's Textbook of Pediatrics 21st edition. I'm sure you know all about birth dose of OPV and why it is given. In case something has missed your attention, a dose of OPV administered at birth or as soon as possible after birth can significantly improve seroconversion rates after subsequent doses and induce mucosal protection before enteric pathogens can interfere with the immune response. The second part is well taken because before the enteric pathogen, once you have the enteric pathogens, enteroviruses, etc. in the stomach or in the intestine, they will compete with the OPV for multiplication. Now, in this, that is well taken. But how does it significantly improve the seroconversion rate after subsequent doses is a little difficult to understand because OPV is a live vaccine and each dose is either a all or none phenomenon. Once it is successful, it should multiply in the body to produce a high antibody level. Leaving apart, there's another very common question asked is, will not the maternal antibodies affect the newborn OPV? Because you are giving it at a time when the maternal antibody level is very high. The maternal antibodies are mostly IgG, and there is no maternal IgA in the gut to prevent the multiplication of the OPV. Another advantage is when the birth dose of OPV is given at a time when the infant is still protected by maternally derived antibodies, may prevent VAP, vaccine-associated paralytic poliomyelitis. Therefore, there's a distinct advantage in that. And however, the seroconversion rate at birth doses varies from region to region. It is very low in India. It is 10 to 15% in certain studies, while in median in Egypt is 32%, and South Africa it is 76%. The reasons for this are not fully known. Though not part of the neonatal vaccination of polio, I would digress a little into pulse polio vaccination because there are some worries about it and there are some controversies regarding that. And this is normally referred to as National Immunization Days. Now, The NIDs are necessary in developing countries to rapidly increase the immunity level in the population to achieve and surpass herd immunity threshold for poliomyelitis and hence rapidly interrupt the transmission of wild polioviruses. So therefore, you're flooding the community with vaccine poliovirus, which does not cause any poliomyelitis, and therefore more than 90% are probably given this virus. There is no scope for the wild poliovirus to transmit in the community. That's the idea behind it. The NIDs are conducted twice annually at a period of 1 to 3 days when one dose of IPV is administered to all children below 5 years of age, regardless of prior immunization history. A second dose is similarly given after 4 to 6 weeks. Now, nowadays it has not conducted that religiously due to multiple reasons because of COVID epidemic and all. But what is a little controversial, even doctors get it perplexed, is regardless of the prior vaccination history. Now, if a child has received his one routine immunization today, should he come next day for his if the national immunizations day is there? People are vague about it, and generally, whoever comes is given. And then what happens all this is that at the end of the day, the people who have taken the regular immunization keep on taking the national immunization days, the pulse polio also, because at the same time, people who are not taking the poliomyelitis never come back to take the pulse polio also. Therefore, this is a problem which is there in the ground reality. But anyway, that's a national program and you have to go ahead with it. Now, the national immunization are conducted during low transmission season, not during rainy season, because you don't want so that other enteroviruses may not interfere with your poliovirus seroconversion. We don't want other enteroviruses to multiply and interfere with the polio vaccine virus you have given. Now I'll give you a few rapid fire points which makes me little concerned about the pulse polio. Now, OPV should not be given to pregnant women, of course we will not, or household contacts of immunodeficient patients. Now, I would like to ask you as a pediatrician honestly, how many of you have asked when you are given an OPV, especially nowadays in private practice, you give OPV during pulse polio and not that much in regular immunization. How much have you asked whether anybody in the house is on cancer treatment or is immunosuppressed due to severe diabetes or taking immunosuppression drugs due to some other reason like high dose steroids? If you are not, ask your conscience, is it right? One of the advantages of pulse polio is, of course, the cold chain can be better maintained for short campaigns, and therefore this might be more effective in the rural areas. Now comes next 3 points, which I say must definitely make you think. No data are available in developing countries about the duration of mucosal immunity for polioviruses. Now, if I have given you oral polio, and if there is mucosal immunity, naturally your pulse polio will be a waste, because when the pulse polio is given, the organism cannot multiply and cannot be excreted in the intestine to flood the community with vaccine polioviruses. Now, one study reported that children were completely resistant to intestinal infection 10 years after vaccination. Therefore, if I give you regular vaccination and for 10 years you are completely protected, mucosal protection is there, how in the hell is the pulse polio going to be effective? Remember, even if you are given the neonatal polio, the IPV is supposed to boost mucosal immunity better than even OPV. But there are, of course, the intestinal immunity induced by OPV does not persist beyond a year. There are studies like this also. So there were controversial evidences regarding mucosal immunity. But without that, we are embarking on a national program. Putting the whole health personnel for nearly twice every 6 months. Their time and money is utilized for this. Not very sure whether mucosal immunity is there or not. Now, the another question that is often asked is, okay, the mucosal immunity is not there, but once you have immunized, the IgG immunity is there. Will not it come and attack the virus in the mucosa also. The immune memory and vaccine-induced protection is a race between reactivation microbial invasion. The prompt reactivation of the immune memory is not sufficient to control polio replication in the digestive tract. I'll tell you what it is. The memory cells, B cells, are present in the lymph nodes and the spleen. And the oral polio which you are giving for pulse is in the digestive tract. Forget the IgA. The IgG is supposed to come round and attack it it will take some time. By the time the mucosal cells, the intestine, the polioviruses would have multiplied. Therefore, the immunological basis of pulse polio vaccination is little questionable because we are not sure how long the intestinal immunity lasts. If the intestinal immunity is there for 10 years, definitely your pulse polio is not going to be that effective. Therefore, we are not on very safe grounds or on very, just like oral polio seems to be having a sound immunological basis, but pulse polio is a little ambiguous regarding its the immunological basis for pulse polio vaccination. When coming to the end of this presentation, let me reiterate that I have not covered A to Z of all aspects of hepatitis B and OPV vaccination at birth, and neither have I touched on BCG vaccination. I have picked up some points which I thought will be of significance to you and may not have caught your eye. Some of you wouldn't have thought about those aspects. Now I am Dr. A. Padmanabhan, and my other educational videos can be found in this link. And I also blog on wordprocess.com, and you can find them in this link. Thank you for listening, and bye till we meet next time.